Yeah,
Yeah,
yeah.
yeah.
Beginning of the
Same,
year.
same.
I
wish you happy new year and
Thank you.
may be happier every year as the
Thank you,
year
sir. Thank you
goes
so
on.
much.
Through we
I
can
think it's
start.
time. Yes. Shall we
Many
start, sir?
persons
Okay.
join in
We can
YouTube. I
start.
think we can join. We can
Okay.
start.
Well,
Yes,
I'll
sir.
just join. It's okay, sir. Okay. Good evening, everyone. It gives me great pleasure here to the second installment of the pediatric dialogues between the national experts. So let me start the program today with the pediatrician's prayer. எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் ஜாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். Uh, Grant us the equality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love, and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things which we can, retain the good, and accept within reason the things we cannot. Grant us your blessings, grace, and mercy in all situations, at all times, and amidst all people. Thank you. Uh, Now I welcome the faculty for today's evening, Dr. Rachna Das Asarika and Dr. Madhu Puja, and I request our President, Dr. Rajendran sir, to inaugurate today's session. Over to Dr. Rajendran sir.
Thank you, Dr. Thuru, and respected scientific advisor and Vice President, South Zone 2024, Dr. Professor Singarvelu. He was a former Dean of Tanjavur Medical College. He is a well-known academician. On behalf of IAP TNC, welcome Dr. Singarvelu, sir. And I welcome Dr. Balashankar, President 2024, and Somasundra, President-elect, Gopal Subramanian, Vice President, and Dr. Narmada, Honorary Secretary, Rajkumar Trisra, and our 24/7 academic coordinator and is pillar of IAP TNSC, Dr. Thirumurugan. And on behalf of IAP TNSC, I welcome and central as well as state EB members. It is a wonderful day because it's a pediatric dialogue with the national experts. We are concentrating on national speakers. This month topic is pediatric metabolic disease. Mostly it's underdiagnosed conditions. I think both Dr. Rachna Das Gasarika, she's a professor of pediatrics and a senior consultant pediatrician, Guwahati and Assam, is a well-known pediatric emergency person as well as pediatric intensive care also she's dealing. On behalf of IAP TNSC, I welcome Dr. Rachna Das Gasarika, and she has wrote, I think that's pediatric emergency preparedness at school. I think it's a well-known module also. On behalf of IAP TNC, I welcome Dr. Rachna, madam. And I welcome Dr. Madhu Puja. He is a professor of pediatrics, JJ Medical College, Davangere. And he is going to talk about when to suspect IEM in children. Both are excellent speakers, and I think we are going for a lot of deliberations. Definitely that our postgraduates as well as our practicing pediatrician definitely will get a wide knowledge and as well as how to approach this metabolic disease. Over to Dr. Thirumurugan.
Thank you, sir. Now I request our scientific advisor, Dr. Singarulu sir, to say a few words before we start the program.
Thank you, Tirumurugan Academy Coordinator, respected President and all the dignitaries, my beloved teacher, Dr. Professor Srinivasan sir, and today's speakers, both are my very close friends, Dr. Madhubujar from Davangere and Rashna Das from Assam, who is along with me in the NRC chapter also, and Madhubujar is one of the known dynamic person in Davangere, apart from academics, he is a very active person. Rasnadas in Guwahati, well-known professor and teacher. So I'm happy that both of them accepted and to be with us in the National Dialogue Program. One of the very important our presidential action plan. Our the President Rajendran has a lot of presidential action plan this year, which is almost unique to our nation, IIP. This is one of that program which is being going to be conducted. I don't want to stand before science. Wish you all the best. Thank you for giving me this opportunity. Over to
Thank
you.
you.
Thank you.
Thank you, sir. Thank you, sir. Just a couple of words on this particular program. So, what we basically aim at is to choose a topic, a common topic, and get two experts from the all over the country to give their viewpoints in about as a presentation for about 20 minutes, different areas of a particular topic, and then follow it up with discussion where we can clarify our doubts and questions. And this is something which gives you a perspectives from real experts, and that is something which we are privileged to have today, Dr. Rashna Das and Dr. Majapudar. So, without wasting much time, I'll now start with today's session with Dr. Rashna's first presentation on metabolic syndromes in children. Over to Dr. Rashna.
Thank you. Can you see my screen?
Yes, ma'am.
Yeah. So thank you very much to the Tamil Nadu IIP chapter for inviting me. It's a pleasure, and my respects to all the seniors who are here. Without wasting much time, I'll start off this with a case study. In 2016, we did a school health checkup in Guwahati, and we found this boy, a 6-year-old, with a BMI of 31. His blood pressure, which we checked multiple times, was more than the 95th centile. He had acanthosis nigricans, as you can see. And so we were thinking, is he a pre-diabetic? I had to speak to the mother. Mother was really upset that we were thinking of such conditions in our child. Then we followed up with the screening of the entire school in 2016 December. A total of 832 students were screened, out of which 40, that means 4.8%, were found to be overweight. And among the overweight children, 19 of them had pre-hypertension, or which is otherwise known nowadays with the new terminology, that is elevated blood pressure, and 4 were frankly hypertensive. Obese we found in 5.7%, that is 48 children. Again, 11 of them had elevated BP, and 17 of these 48 children were hypertensive. So this is really a problem these days. I'm sure it's being seen even in your state. And we have reports coming in from all over the country that the problem of obesity, overweight, and hence metabolic syndrome is on the rise. So my topic today is on metabolic syndrome in children, the risk factors, and the clinical management. I'll take you through the definition, the epidemiology, how do we measure when we see these patients, the pathophysiology, risk factors, and finally, the management. So this is the most important paper which I think was published in the last century, the fetal and infant origins of adult disease, the Barker hypothesis. And I'm sure those who have read find it very interesting that a group of preterm, low birth weight infants followed up into adulthood were revealed to have hypertension, diabetes, and other metabolic problems like cardiovascular diseases. Now, this is a huge problem in our country. We know that we have a lot of low birth weight babies as well as preterm deliveries. And if you take the context of this study, then perhaps we are actually already sitting on a time bomb of metabolic syndrome. So how do you define metabolic syndrome? It is a constellation of physiological, biochemical, clinical, and metabolic factors which directly increase the risk of future atherosclerosis, type 2 diabetes mellitus, and all-cause mortality as an adult. So if you look at the adult definition, there are a lot of definitions by WHO, by the National Lung Heart Institute, and as well as the International Diabetic Federation. But if I need to summarize the adult definition of metabolic syndrome, the criteria, they're supposed to fulfill 3 out of the following 5. First is the elevated waist circumference. based on population and country specific definition. So this is an important aspect. That means population and country specific definition. Second is a systolic blood pressure of 130 millimeters or more and a diastolic BP of 85 millimeters mercury or more, or if the patient is already on treatment for hypertension. The third is a fasting blood glucose of 100 milligram per deciliter or more, or the patient is already on treatment for hyperglycemia. Triglycerides of 150 milligram per dl or more, or on treatment with drugs to reduce the hypertriglyceridemia. And lastly, the HDL cholesterol, which is less than 40 in males and less than 50 milligram per dl in females, or it could be that the patient is already on treatment for reducing the low density lipoprotein and the very low density lipoprotein cholesterols. Now, in pediatrics, there is no consensus on the definition, but what has been suggested is, like, you look at the defining variables, the age, there is an International Diabetic Federation definition and something given by Cook et al. So the defining criteria in less than 10 years, it cannot be diagnosed in this age group. But in those between 10 to 16 years, they say that they should have a central obesity plus at least 2 out of the 4 following criteria. Cook et al. Says that you should have 3 or more criteria to be fulfilled. So central obesity in 10 to 16 years should be more than the weight circumference should be more or equal to the 90th centile, or adult cutoff if lower. Same given by Cook et al. In the age group, which is less than 10 years, since we don't have a definition for this age group, but if you find that the waist circumference is more than 90th percentile, then assessment should be done if there is a family history of metabolic syndrome, type 2 diabetes, mellitus, dyslipidemia, cardiovascular disease, hypertension, and or obesity. Now, as for hypertension, the criteria are the same as per the idea of definition, but Cook et al. Defines it more specifically for children by saying that the blood pressure should be more than or equal to the 90th percentile for the age and height of the child. For triglycerides, the definition is more than 150 milligram per dl, but Cook et al. Gives a lower cutoff at 110. HDL is less than 40 for children for both the criterias, and impaired glucose for the idea of definition, it is 100 milligram per dl, or you could have an older child who is already on treatment for type 2 diabetes mellitus. And for Cook et al., he says that the fasting blood sugar should be more than 110 milligram per deciliter. So based on these definitions, we can identify the metabolic syndrome in children. Now, coming to the epidemiology, is it really there? What is the epidemiology worldwide? So I quote from this study from Translational Pediatrics 2017, where they say that the childhood obesity, as we know, has become a worldwide epidemic. Globally, there are about 1 billion overweight adults and 475 million who are obese, and the numbers are perhaps increasing by the day. Children, they have defined that they have identified about 200 million overweight children, out of which 40 to 50 million are obese. And the most important thing to note here is that the prevalence of metabolic syndrome is driven largely by the prevalence of obesity in the community. So the prevalence ranges from 0.2 to 38.9%, depending on which part of the country you are and which community you are born to. The systemic review of 85 studies showed that the median prevalence is around 3.3, with a range of 0 to 19.2%. Overweight children are around 11.9%, obese are around 29.2%, and the range of the obese children range from 10 to 66%, again, depending on which part of the world you're collecting the data from. In the non-obese, non-overweight population, the incidence of metabolic syndrome is very, very low. It's about 0 to 1%. Now, 90% of the obese or overweight children have at least one feature of metabolic syndrome. The risk is more in East Asians, Asian Indians, Native Americans, Hispanics, and the Japanese Americans. Obviously, this is a study from the US. Now, if you look at Canadian data, the prevalence is around 2.1%, but they have found that at least 1/3 had one clinical feature of metabolic syndrome, the obese children. And the most prevalent single risk factor for metabolic syndrome is the presence of abdominal obesity. Now, looking at data from India, the first publication which I could come across was in early 2010, where it was an editorial written by Dr. Ashraf Ghani discussing about the alarming rise in metabolic syndrome in the Indian children. Then we had studies from New Delhi by Nikhil Tandon et al., where they looked at the prevalence of metabolic syndrome among urban Indian adolescents and its relation to insulin resistance. So here they found that the prevalence was around 3% by the metabolic syndrome IDF definition and around 4% by the ATP definition. Females were more affected than males. Central obesity was most common. All of them had elevated triglycerides and a low LDL. This should be low HDL, dysglycemia, and hypertension. Then we have a study from Eastern India. This is done by Rashmi Ranjan Das et al. From AIIMS Bhubaneswar and published in 2020. Very interesting study. Doesn't reflect the entire Eastern region data, but I think this is good enough for us. So this was again done at Bhubaneswar, where they looked at school children from 6 to 16 years. About 2,000 children were screened. The incidence of obesity and overweight was around 28.2%. Metabolic syndrome was 21.8% in the population. In the 6 to less than 10 years, the prevalence was around 11%, and 11 to 16 years, it was 30.6%, so quite a huge number. Acanthosis nigricans was found in 46.4% of these children who were overweight and obese, indicating insulin resistance in the group, and a positive family history of cardiovascular disease, hypertension, diabetes, and obesity were found in 42% of the population which were studied. And the mean HOMA insulin resistance in children with metabolic syndrome was 5.46 versus 2.18 in those without metabolic syndrome. So indicating that the children who had metabolic syndrome had higher insulin resistance. Coming to another study from, again, North India, this was done by Somia Ramesh et al., and this was multicentric, including 3 or 4 centers, AIIMS, PGI, Chandigarh, as well as so a few centers in Delhi. And they did an extraction of data from the Comprehensive National Nutrition Survey, looking at children who were 10 to 19 years of age. And they found the incidence, the prevalence of metabolic syndrome to be about 5.2%. The males were more affected than the females. Urban, obviously, there were more children affected than the rural. Higher socioeconomic status, more affected than lower socioeconomic status. Again, central obesity was found in approximately 12%, hypertension in 15%, hypertriglyceridemia in 26%, low HDL in 32%, and an elevated fasting blood sugar in 3.7%. So this was the Comprehensive National Nutrition Survey was done in 2011. So they did a mathematical projection for 2017 and calculated out that at that point of time, nearly 14.2 million adolescents in India had metabolic syndrome. So that is quite a number. Then another study was done and published in 2023 from, again, AIIMS. And it was a meta-analysis. Initially, they started off with somewhere around 2,300 studies, but narrowed it down to 16 studies involving 19,000 adolescents. And the pooled prevalence of metabolic syndrome was 3.4%. And it was found that the prevalence of metabolic syndrome was higher in Indian adolescents when you compare to other countries who were at risk, like Southeast Asian countries. This is a study from Karnataka, which looked at association of early life factors with metabolic syndrome in school-going adolescents of an urban South Indian population. And here they found, again, the prevalence to be around 11%, more in those with abdominal obesity. In this study, they found that there was no protective association with initiation, exclusivity, and total duration of breastfeeding. But they also found that there was increased risk with low, middle socioeconomic status, if they had a family history of central obesity, hypertension, high BMI, high triglycerides, and low HDL. But another interesting finding which they quoted in the study was that there is also a small proportion of lean individuals prone to metabolic syndrome for some reason. Then if you think that it is only a problem of the urban, no, it is not. And rural childhood obesity is an emerging health concern. So this is from Chennai. And they found that obviously the urban versus the rural overweight as well as the obese children were more. But what was interesting in this study was that rural children had increased prevalence of overweight and obesity, 16.2% compared to being thin or severely thin, which was 12%. So which means that even the rural children are now becoming overweight and obese, and this is a disturbing trend. The highest prevalence in boys was around at 5 to 6 years of age, whereas in girls, it was in the post-pubertal age, around 15 to 16 years. So that was about the epidemiology as we have it now. Probably we will need more studies for different populations. For example, in the Northeast, we have different kinds of tribal people varying from states to state and even in the same state in various areas. So we do see a lot of obese children and overweight children, and probably we'll need more studies to exactly find out what's happening. How do you measure? So when you have these children coming to you, what are the things that you need to look at? So first is what to measure. Is obviously like any other pediatric disease, most important is the anthropometry here, where we would look at the BMI value for age, the waist circumference, the abdominal skin thickness, and the triceps skin fold thickness. Then comes the clinical parameters and metabolic dysfunctions. We would also like to look for conditions which have predisposed or biochemical parameters which predisposes this patient to type 2 diabetes mellitus, like a higher insulin resistance and other cardiovascular diseases. So the IAP growth charts for boys and girls are there separately. I don't need to explain to you, and they can be used for plotting the height and the weight and then finding out the BMI. These are the BMI charts from CDC, but we also have BMI charts from IAP, and they are good enough. And as you can see, they are very well, they're, above the 50th centile, you have an orange line, which tells you the adult equivalent of being overweight. And the red line is when you have the obesity. So this will differ, the numbers will differ according to the age. But the main problem with this BMI is that whatever BMI has been defined in the Western population probably does not hold true for Asians, and particularly for Indians, because they found that in Asian people with a high risk of type 2 diabetes and cardiovascular disease occurs at BMIs lower than the existing WHO cutoff of overweight, that is 25. So probably even for our population, even in children, even at a lower BMI, these children will become prone to develop metabolic syndrome. The second is the waist circumference. So again, here we have, these are the IAP, from the IAP website, you will find the Khadilkar charts for the waist circumference, different for age in years and for boys and girls. So anything which is more than the 90th centile for age and sex is considered to be high. And for example, if it is at 15 years, say, then somewhere above 70 would be, the 50th centile is at here, but somewhere in here, it will be at 85, it will become indicative that this patient can have a metabolic syndrome. So there are other anthropometric studies. This was from Vellore, which they looked at the anthropometric measurements for the prediction of metabolic syndrome. And they looked at around 1,349 subjects at the age range of 14 to 25 years. And they have said that the waist circumference and abdominal skin fold thickness more than the third quintile cutoff is significantly associated with metabolic abnormalities. The sensitivity of either of the measurements, that means the waist circumference or the abdominal skin fold thickness, to predict metabolic abnormality is 66%, And importantly, the negative predictive value is 82.8%. If there is an increased abdominal skin fold thickness more than the fourth quintile, then it significantly is associated with hyperglycemia in this group of patients. We have a recent study again from Salem in Tamil Nadu, which looked at these triceps skin fold measurements and the risk of metabolic syndrome in overweight and obese children, published in the Indian Pediatrics in November 2024, very, very recent. So this was a cross-sectional study done in the institute, which looked at children between 10 to 16 years. And out of the 60 children which they had studied, they found that 28%, 17 of them had metabolic syndrome. And this is what they found when they compared the parameters with the patients who had metabolic syndrome and the ones who didn't have. And you see the triceps skin fold thickness was 29.4 versus 24.3. And this was statistically significant. And the cutoff of 26.7 millimeter was predictive of metabolic syndrome with a sensitivity of 85% and a specificity of 72%. Now, this study is important in the sense that this is a non-invasive way of predicting that a person or a child or an adolescent may have metabolic syndrome. Now, the other metabolic abnormal alterations which can be seen are the biochemical ones like a low HDL, high triglycerides, impaired glucose tolerance, presence of type 2 diabetes, and cardiovascular disease. And of course, the blood pressure measurements, which have to be plotted. It's not a very good picture, but it has to be plotted against the chart for as per the age and the height percentile. So for example, an 11-year-old male with a height at 10 centile has a BP of 125/78. So we will look at the 10 centile figures. So 125 means the 99 centile for the age. And the diastolic would be 78, which is at the 95th centile. So this is how we plot for hypertension in these children. So this is, we will have to do this exercise with each and every patient, because for children, we have to look at the blood pressure charts. Now coming to the pathophysiology. So this is a complex interaction between genetics, epigenetics, environment, diet, and physical inactivity, some of which we can control, some of which we cannot. It starts in utero with a maternal nutrition. If there is a poor maternal nutrition or, on maternal nutrition, which is not in the right proportion of carbohydrates, proteins, you'll end up getting low birth weight and preterm babies, which are already, we know, at a higher risk of metabolic syndrome as per the Barker hypothesis. Second is the feeding of infants. We need to give these infants optimum protein quality, not quantity, because it has an impact on long-term in health. And the diet choices as children have proven to have a great impact on the development of metabolic syndrome. So there is an importance of nutrition in early infancy. And because it has been seen that the disposition to overweight and obesity is not solely determined by the genetic makeup. So there is an environmental stimuli like nutrition and hormones, and it undergoes epigenetic changes, which is known as early metabolic programming. The prevalence of later obesity with breastfeeding was extensively studied in Germany, where they found that the impact of breastfeeding on the risk of obesity and the risk of being overweight was there. And they found that those children who were never breastfed had a higher prevalence of both overweight as well as obesity than children who had ever been breastfed. And breastfeeding and prevalence of later obesity was associated with the duration of feeding according to the study. So if you're never breastfed, then you have an overweight of being 12.6% and obesity of 4.5. If you're breastfed sometime, the being overweight prevalence goes down to 9.2 and being obese to 2.8%. And if you're breastfeeding for more than 12 months, the prevalence of obesity goes down further to 0.8% and of being overweight to 5%. So this highlights that you need to breastfeed our children for a longer time, at least up to 2 years of age. Now coming to metabolic programming, there is a critical window in the first few weeks of life, regardless of the gestation or birth weight. And if these babies are growing faster in the first few weeks, it has been found to be associated with later insulin resistance and endothelial dysfunction. So this is important. I wanted to highlight this because our parents, if suppose a baby is born preterm or low birth weight, are, in a rush to catch up to the weight of a normal baby. Now that rush to make the baby gain weight faster will actually result in later insulin resistance and endothelial dysfunction, which was beautifully studied by Singhal et al. In this study, which was published in Circulation in 2004, where he looked at the flow-mediated endothelial-dependent dilatation of the brachial artery in adolescents. He took a group of adolescents who were born preterm with weight gain above median and weight gain below median, and the controls were the age-matched adolescents born term. And what he found was that the ones who had a higher weight gain had lower, endothelial-dependent dilatation. So this is in controls, term controls, where the dilatation was good. This is in low weight gain, where it was very good. But if you had higher weight gain, your endothelium was resistant to dilatation. So indicating that changes have occurred very early in these babies. So the implication of this particular study is that early nutrition and rate of weight gain in the first 2 weeks of life determines the elasticity of our arteries for lifetime. And this is what we need to explain in simple terms to these parents who insist on making their children grow or babies grow very fast. So there is a very intricate and complex relationship between nutrient excess, deficiency, glucocorticoid exposure, and oxidative stress during pregnancy, affecting the intrauterine growth, leading to the thrifty phenotype, and finally leading to metabolic syndrome, type 2 diabetes, and cardiovascular disease. Again, metabolic dysprogramming can occur because it is amino acid dependent. So there are some amino acids which are insulin-releasing amino acids like valine, leucine, isoleucine, threonine. And if they are present more in the diet, they will lead to more insulin-like growth factor, early weight gain, and increased adipogenic activity. So which means the protein quality for long-term health, you have to know that all proteins are not the same. There are some proteins which are not good for health. So proteins usually are required in our body for everything, right? From hair growth to bone growth and muscle growth. But there are some proteins which are essential, and then some are conditionally essential amino acids. So these are also required. And we know that breast milk is the gold standard for protein quality. And what determines the protein quality in breast milk? It is the amino acid profile and the whey-casein ratio. So we know breast milk contains less casein and more whey compared to cow's milk, which is exactly the opposite. Why this whey is important? Because it has the 100% biological value. It has a protein efficiency ratio, which is the highest, 3.2, and a net protein utilization of 91% compared to the casein and soy. So what does it indicate? It indicates that whey protein is good for muscle development and therefore an increase in lean body mass, whereas casein is good for fat cell deposition, increases adipose tissue and hence subcutaneous fat, and later on leading to insulin resistance. So therefore we need to have more of whey and less of casein. Now, there are some proteins which are more in human milk. For example, tryptophan is more in human milk compared to bovine milk, and it is an essential amino acid. But the protein content in cow's milk is 3 times more than breast milk, but it is not a good protein. The essential amino acid content, especially tryptophan levels, are less, and therefore the cow's milk will overcompensate by adding other kinds of protein. So it is the insulinogenic proteins which are more in cow's milk. I wanted to talk about this because we need to explain to our parents that it is not good to feed our children cow's milk all the time, especially in North India and even in our part of the country. They're very insistent among certain communities on feeding cow's milk. So the missing part which is there in the bovine milk is oversupplied by adding threonine and branch chain amino acids. And they have found that these are insulinogenic, and especially the glycomacropeptide, which is in high content in bovine milk. And this glycomacropeptide has been known to inhibit acid gastric secretion, modifies the blood concentration of regulatory digestive proteins. It was proposed to induce satiety, but the effect is not seen in human studies. What is seen is that if the more the glycomacropeptide, the more is the weight gain, and therefore they significantly affect, which is statistically significantly affecting the weight gain and predisposing these children to long-term insulin resistance, which has been found from this Framingham cohort study, where the branched-chain amino acids and the risk of type 2 diabetes mellitus were studied. So what is the implication? The blindly adding more proteins of various kinds in infant diet, especially cow's milk, is not really good. And the branched-chain amino acid in glycomacropeptides predisposes children to development of metabolic syndrome. Coming next to the diet exposures and choices in childhood, we know that the Western diets have more sugars and fats and in compared to the traditional Indian diet. Now, these Western diets, which are high in sugar and fats, are hyperphagic because the more you eat, the more you feel like eating. You keep on trying to eat more. For example, if you have a packet of chips, you like to finish the whole thing and maybe go to a second packet. And this kind of a hyperphagic behavior increases obesity, and therefore you have early cardiovascular changes. So the fatty atherosclerotic streaks in arteries can occur as early as 2 years of age. Now, which are the changes that occur? There will be altered lipid partitioning because of obesity, endothelial dysfunction, insulin resistance, and finally leading to metabolic syndrome, type 2 diabetes, and long-term cardiovascular diseases. It also causes low-grade inflammation, disturbance in hemolysis, fibrinolysis, and adipokine secretion in the liver, and hence the increased incidence of fatty liver. And so there's by a complex mechanism involving gene, adipose tissue inflammation, insulin resistance, you'll end up with a lot of problems, including the non-alcoholic fatty liver disease. So the non-alcoholic fatty liver and metabolic syndrome, which was studied, they have said that the non-alcoholic fatty liver disease is actually a hepatic manifestation of the metabolic syndrome. And in many of these children, when we do the ultrasound, usually we will find grade 2 or grade 3 fatty liver. Genetics, yes, there is some role of genetics. There is a 40 to 50% inter-individual variation. If one parent is obese, it increases the risk in the children by 2.2 to 3.2 fold. If both the parents are obese, then odds ratio increases more. If you're an obese child or an adolescent, you become an obese adult. And in monozygotic twins, there's a 31.6% increased chance of obesity, diabetes, hypertension compared to the dizygotic twins. A lot of genes are involved in lipid metabolism, insulin signaling, glucose metabolism, and adipokines, like all of them. A lot of studies are going on whether we can modify these genes or not. But if you talk of metabolic children, the risk factors in obese children and adolescents, they found that maternal gestational diabetes, lack of infant breastfeeding, and microalbuminuria in obese children and adolescents are 3 of the most important risk factors for development of metabolic syndrome in these obese children. So coming to the management, how do you manage? There are a lot of management issues. The diagnosis and convincing parents is a huge challenge because they don't want to accept the fact that their children are obese. They would say they are healthy. It has to be multi-pronged. It is not a one-time affair. And there is a huge program dropout. People don't stick, even the adults don't stick to their programs, so forget about children. But we have to outline a dietary management, exercise, behavioral modification, and the role of pharmacology and surgical intervention is very limited, in fact, not talked about in children. Prevention is a key in the management. The diet, again, is family-focused and never child-focused. So the entire family has to change their diet. It is found that if you collaborate with the school, there is more better response. A carbohydrate and fat-restricted diet has to be given with more proteins, fruits, and vegetables. And switch to healthy drinks. Focus on water and stay away from soft sugary drinks and fruit juices. So we encourage them to take more of fruits rather than fruit juices. This study, which was done to find out what works best, they found that the schools are a promising venue for intervention. The community-based participatory research approach is best, and there are better outcomes than traditional methods. So schools as a promising venue for intervention is because, they have found in the US that if you take away the McDonald's and the KFCs from the school environment, the number of obese children are being controlled. Now, coming to exercise, obviously, increased physical activity has to be there, but we have to also reduce the TV and the computer time and encourage community sporting outdoor activity. So the research, what does the research say? This was published in 2015 in the Journal of American Heart Association. And this analysis showed that exercise significantly improved cardiorespiratory fitness and some cardiometabolic biomarkers. Now, how much time should they exercise? So this study published in 2014 has given us a number which says that 88 minutes of moderate to vigorous physical activity per day is an effective for metabolic syndrome. So 88 would mean at least 5 to 10 minutes of warming up, around 60 minutes of good exercise, and then another 10 minutes of warming down. So that would be approximately around 80 minutes of exercise is good enough. Then 5 or more fruits and vegetables in the diet, 2 hours or less of recreational screen time, 1 hour or more of physical activity, and 0 sugary drinks, more water. This is what we would like to tell the parents. And keep the TV and the computer out of the bedroom. No screen time under the age of 2. Now, this is becoming a very difficult proposition because many of our mothers are now using the mobile to feed the children. So this is becoming a big problem. Now, this is what I like to show to my parents who come to me when I counsel them about the diet. This is the My Plate. And you see beautifully, this tells you that in the entire plate, 50% of your plate should consist of vegetables and fruits. The rest 50% will have grains like rice, wheat, and the other grains like oats, barley. Then the other 25% would be protein, which is in the form of nuts, beans, peas, lean meat, seafood, fish, and a little bit of dairy. So that is only once a day. And best is to take skim milk or non-fat yogurt. And this should be low in fat and sodium and sugar. So without sugar, better to be taken. So once you draw this figure on the prescription and you give them an idea, then they usually are quite happy to try to follow it. Next comes the behavioral management, where stress handling is important, particularly in adults and adolescents, because they are affected by the body image and, of course, the peer group pressure. Motivational interviews with positive reinforcements are to be done whenever they come to you. So even a 500-gram weight loss is to be encouraged. And we need to give them small reachable goals, not that you lose 5 kg in a month. You say, okay, you lose 500 grams to 1 kg in a month. That is also good. Stress on consistency. And then we need to educate the parent on food choices and the availability so that they also change their behavior of what kind of food they get into the house. Now, about pharmacologic management, the first step is, of course, diet and exercise. Medications are given very short term in the extremely obese ones, which could be in the form of statins, fibric acid derivatives, and cholesterol absorption inhibitors, but they are not used usually in our practice. So this is another study which actually looked at the early life exposure to Western diet and the effect on metabolic syndrome in mice. And they found that if you give a Western diet, they had more BMI, more consumption, that is hyperphagia or the hedonic response, raised plasma insulin and triglycerides. And exercise with high aerobic capacity reduced the resistance to diet-induced obesity and associated comorbidities. So next is the last part, that is prevention, which is actually the key. So it starts with a healthy adolescent girls, healthy pregnancy planned at the appropriate age with a nutritious diet, prevention of IUGR and preterm deliveries, and supply of important and essential micronutrients and amino acids for proper intrauterine growth, followed by exclusive breastfeeding up to 6 months, continued breastfeeding with complementary feeding up to 2 years of age, If using additional milk, it is better to avoid cow's milk because of the high glycomacropeptide, which induces metabolic syndrome. So most of the time you can explain to the parents that actually you don't need to give additional milk to your children. In childhood, we need to stick to our traditional foods, avoid the Western diets, and look at the labels while picking up food at the supermarket. So this is already there in IIP program where they teach the students to look at the labels and the calorie counting. So I think that is a very good way. I see it in my own child, in my son. Whenever he picks up something, he will always obviously go for a healthier choice these days by looking at the labels. So eye-level marketing techniques are there everywhere. I'm sure it's there in Tamil Nadu also, where it is attractively all the goods are stored and you feel like picking up everything, especially the packaged goods. But we need to move away from these and buy mindfully, and of course, move away from the frozen to the fresh section, because the fresh will be better for a better metabolic health. So this is a very beautiful song written by Frank Sinatra, Killing Me Softly. And I thought I'll show you this because this is what is a very nice article published in 2011, where it says, Killing Me Softly, the Fetal Origin Hypothesis. And I think this is something important for all of us to read if we want to prevent and take care of metabolic syndrome in our country. So thank you very much. And thank you for the opportunity given. I hope I am on time. And if there are any questions, then I'll take it on.
Thank you, ma'am. Thank you very much for a very illustrative lecture on metabolic syndrome. I think we'll listen to Dr. Manoj Pujar and then we'll come back to questions if that's okay with you. Okay, over to Dr. Manoj.
Wonderful, wonderful presentation, madam. Hats off to you.
Sir, are my slides visible?
Yes, sir. Yes, sir. It's visible, sir.
Yeah. Sir, am I audible, sir?
Yes, sir. Audible, sir. Audible.
Okay. Yeah. So at the outset, I would like to thank the IAP of Tamil Nadu State Branch for giving me this opportunity to speak on this subject. When to suspect IEM in a child and what next? So I acknowledge the presence of our friends, Dr. Singaravelu sir, and teacher of teachers, Dr. Srinivasan sir, who is there in the audience section. Friends, there are some questions to ponder before I start my talk. So actually for the practicing pediatricians, so how common are the IEMs in our clinical practice? So that is the major questions that a practicing pediatrician would ask. If you ask me, so this IEMs are not that uncommon. We do see them in our clinical practice very often. That means, are we missing those IEMs, which if it is that common? That is the one of the questions to ponder. And most of us will also think that it is difficult to diagnose a patient who has IEM. So I think probably that's a myth, and we will go on to understand how easy it can be to diagnose an IEM after this talk. And is there a treatment available? So these are the points that usually comes to the mind of a practicing pediatricians when they start thinking about IEM. So my talk would be on the introduction of inborn errors of metabolism, and I would present some case scenarios that we have seen in our ICUs and in our general wards, and we will see how these IEMs will present. And as clinicians, we always should be looking for those clinical clues in those patients to pick up the clues and make a diagnosis. And investigating a child with IEM is very, very important. How to investigate and when to investigate and what investigations to send. And of course, the treatment of IEM. Inborn errors of metabolism are nothing but they are inherited metabolic disorders. And we all know that they are due to block in the chemical pathways due to an enzyme, or it could be a cofactor or a transporter deficiency. And any of these block in the chemical pathways would ultimately lead on to the absence of the functional protein, which would contribute to the signs and symptoms of that particular disease. Or it could be the accumulation of a substrate Okay, so the particular chemical compound is not formed, and the previous substrate which gets accumulated in the body, that would cause the organ dysfunction and all the symptoms and signs of IEM. IEM individually, if you take, uh, they are relatively uncommon, right? For example, if I take only as a case as a case of maybe alkaptonuria, so it may be uncommon, right? So if you take it as a collective, so it becomes very common. So the incidence of IEM can be as high as 1 in 800. And this accounts for a significant mortality and morbidity, especially those IEMs which presents very acutely and which needs admission in the ICU, and which accounts for 4 to 10% of ICU admissions. And among those 4 to 10%, the mortality is pretty high, up to 30 to 35%. And as most of these IEMs which presents acutely to us, so they frequently present with life-threatening crises that require immediate treatment. And the number of IEMs of nowadays, because of the advent of all these genetic tests, so it is increasing day by day. As of now, we have more than 1,000 IEMs, with us. And suspicion is the key in making a diagnosis of IEM, as most of these IEMs, they present like any other diseases, especially like infections and other deficiency states. So this paper looked at how common is the IEM in our country. So as you can see, those amino acid disorders and the other metabolic disorders, so they account for almost about 1 in 5,000 deliveries. So if you take that, so roughly we'll have about 18,000 to 20,000 babies being born every year with some sort of a inborn errors of metabolism. And we looked at our own data. So the clinical and laboratory profile of inherited metabolic disorders in our center. And we found that during the period of April 2023 and to March 2024, so we had about 54 patients with diagnosed inborn errors of metabolism. And among that, we can see the fatty acid oxidation defects were the major chunk of it. And we had a quite few of mitochondrial disorders and cystic fibrosis, lysosomal disorders, so on and so forth. So why early diagnosis of IEM becomes important? Because in most of these patients, early treatment is available. So for example, Madam talked about the metabolic syndrome. And these patients, especially with IEMs, can also present with a different type of metabolic syndrome, which we will go on to learn. This treatment is available. Okay, so a child who comes with hypoglycemia, which is a common presentation of a child with IEM, a child can present with metabolic acidosis. We can treat hypoglycemia, right? So we can also treat metabolic acidosis. So treatment is available. And if you treat these children early, so this is going to prevent the neurological damage. And of course, all these inborn errors of metabolism, they have a genetic origin. So we have got a great responsibility with us to counsel the parents about the possibility of another child having such type of disease. And especially prenatal diagnosis becomes very important, especially if the families has been diagnosed to have a child with IEM. So apart from that, we'll go to the case scenarios. So we have a 2-year-old child with us who had come with the status epilepticus, and she was convulsing for a period of 15 minutes. She had 4 admissions previously for recurrent episodes of convulsions. So she had a developmental delay. So developmental age was 1 year. She was labeled as a case of epilepsy elsewhere, and she was started on tablet carbamazepine. She was born to a consanguineously married couple. Elder sibling was a 5-year-old female child, and she was normal. On evaluation, she was hypoglycemic. Her RBS was 20 milligrams per deciliter. Her previous admission record also showed hypoglycemia on 2 occasions, and they got ignored. She did not have any dysmorphic features and no neurocutaneous markers. She did not have hepatosplenomegaly, and her neurological examination was apparently normal. Lab investigations revealed normal electrolytes, normal LFT, normal ammonia levels, and a normal ABG. And we worked up the child for a case of recurrent hypoglycemia. And please remember that any child whom we suspect inborn errors of metabolism who present acutely and where we are thinking the inborn errors of metabolism could be because of a small molecular disease, we get this screening test called as GALAC. So it's an acronym. G stands for glucose, A stands for ammonia, so L stands for lactate, and A for ABG, and K for ketones. So this is the screening test we do in all the patients with IEM who presents acutely to us. And in this child, the glucose was 40 milligrams per deciliter and urine ketone bodies were absent. And that was the major clue. So when a child goes for hypoglycemia, what happens is as a metabolism, so first free fatty acids are utilized for the production of glucose. And for the metabolism free fatty acids, your ketone bodies are produced. So in a child with hypoglycemia, a severe hypoglycemia, if ketone bodies are absent, that means free fatty acids are not utilized, and we can think of a fatty acid oxidation defect. And we sent for a TMS, and we found that in this child there was increase in acyl carnitine levels, and we diagnosed this child to have a medium chain acyl CoA dehydrogenase deficiency, that is MCAD deficiency, which is the common type of IM that we can see. So we move on to a second case. This was a child of a 9-month-old female, brought with fever, loose stools, vomiting since 5 days, lethargy since 2 days, poor feeding, hurried respiration, altered sensorium. There is no history of cough, cold, convulsions, or rashes or bleeding. This child was the second child to a consanguineously married couple. So uncle niece marriage with no significant birth history, developmentally a normal child, and the child was immunized appropriately. There was a significant history in the family. There was history of previous sibling death at 2 months of age with probably a respiratory problem. So they did not had any medical records. On receiving this child, the child was tachycardic, tachypneic, and the pulse volume was low. And this is how the child was breathing. The blood pressure was 66 by 46 millimeters of mercury. The child had a fever, and the child's saturation was 92% on room air, and the child's CRT was more than 3 seconds. There was some dehydration in that child, and the GRBS was 67 milligrams per deciliter. The head-to-toe examination, there were no dysmorphic features. Head circumference was and length for the height were normal. Other systemic examinations did not really reveal any major findings. So yeah, and the CNS, as you could see, the child had GCS of 6 by 15 with no focal deficits or no meningeal signs. And the differential diagnosis that our postgraduates kept at this point of the time was this child was dehydrated because the child had come with loose stools and vomiting. So dehydration with metabolic acidosis. So the other diagnosis was septicemia with hypovolemic shock. So the investigations showed a hemoglobin of 11.4 with a total count of 25,000 with a predominant neutrophilic, and there were some band forms. Platelet counts were a little less. Serum electrolytes were almost within normal limits, with the potassium being at a little higher level. And renal function test, CRP, and chest X-ray were within normal limits. And we suspected a possibility of an IEM in this child because there was a previous history of a sibling death. And on ABG, so the child showed metabolic acidosis. The glucose levels was little less in this child, 57 milligrams per deciliter. Ammonia was little raised. And what happened in this child subsequently was even after the correction of metabolic acidosis, this child continued to have persistent high anionic gap metabolic acidosis. So the sensorium was continued to be drowsy, and the child had obviously acidotic breathing. And at this time, the urine smell was smelling of a peculiar odor. So this was the subsequent ABGs in the child with subsequent bicarbonate correction. So we noted that the child was having severe metabolic refractory acidosis. Obviously, the child also developed hypernatremia. So because of our repeated sodium bicarbonate infusions. So ultimately, the baby required peritoneal dialysis for persistent metabolic acidosis and hypernatremia. So the child took about maybe 6 days for the child to improve. So we sent the TMS report. The TMS report showed increased 3-hydroxybutyryl carnitine levels, and urine GCMS showed multiple organic acids that were present in the urine. So we sent a metabolic screening in this child, and also we sent for a genetic analysis. So genetic analysis showed that the child had HMG-CoA2 synthetase deficiency. It's a type of deficiency which would cause an organic acidemia. So it's an autosomal recessive condition, and the sequencing of the parents were also sent because we had that uncertain significance that being reported in the genetic test, and we also offered for a PND for the next pregnancy. We go on to a third case. So this was a case of a 3-year-old child with a history of failure to thrive, abdominal distension with the recent onset of neurological deterioration. And you can see the parameters. The child's weight is less, height is also less, head circumference is less, mid-arm circumference is less. This child was failing to thrive. On examination, this child had minor dysmorphic features and a massive splenohepatomegaly. And the eye examination picked up a cherry red spot. And we sent a genetic test which picked up an Niemann-Pick disease in this child. So friends, so with these 3 clinical case scenarios that we saw, so when we should suspect an IEM in an infant and a neonate, we should suspect when the history of previous unexplained deaths, that is, it also includes sudden infant death syndrome. When there is history of abortions or IUD or even hydrops, history of HELP syndrome in the mother. HELP stands for hemolysis, elevated liver enzymes, and low platelet count. So if the mother has HELP syndrome, it tells me that the fetus she is carrying, the fetus could have a fatty acid oxidation defect. Consanguineous marriage, so it's a very big genetic clue. I would say it's a genetic clue for us because consanguineous marriage is very common in our part of the country. Maybe it's also common in Tamil Nadu as well. And most of these patients who present acutely, so they will have normal birth events, they'll be normal at birth. And after some times, so especially after feeding, or if they have any minor illnesses, viral illnesses, or a gastroenteritis in one of the patients that we saw, so they deteriorate. So they'll have something called as period of normalcy. Many children would present to us with persistent or recurrent vomiting. So they have acute encephalopathy. They can present with refractory seizures. So many patients with IEM can also present with jaundice, with unexplained liver dysfunction. They have unusual odor. And most important is many a times we suspect these patients could have sepsis or any other normal disease. So they are not responding to the treatment. In all these conditions, we have to suspect a possibility of an IEM. And normally they would present with so-called metabolic syndrome. It's not the metabolic syndrome what Madam has talked about. This is the metabolic syndrome of hypoglycemia, metabolic syndrome of hyperammonemia, and metabolic acidosis. So when should I suspect an IEM in an older child? An older child who comes with an unusual findings in an ophthalmic evaluation, like we saw in one child who had cherry red spot, optic atrophy. If the child presents with dysmorphic facial features, cardiomyopathy or myopathy, a child with chronic liver disease, if the child is having multisystemic involvement, if the child is present with developmental delay and mental retardation, regression of the attained milestones, progressive neurological disease, recurrent encephalopathy. So these are the conditions you should think of. And most of these patients who present in the later age group, so they present with storage syndrome. That is the third case which I showed. So they have some neurological ongoing neurological problems. They present with hepatomegaly and splenomegaly. So friends, coming to the classification, how to classify these IEMs? We can broadly classify into those IEMs which presents basically with an intoxication group, those IEMs who present with energy failure group, storage disorders, predominantly those present with seizures, and those patients who present with liver cell failure or cholestasis. The most common IEMs which have got acute presentation in the intoxication groups are your urea cycle defects, organic acidemias, maple syrup urine disease, and non-ketotic hyperglycinemia. And those with energy failure group are your fatty acid oxidation defects, mitochondrial diseases, and respiratory chain defects. As clinicians, so this is what the metabolic syndrome that I was talking about, metabolic acidosis, hyperammonemia, and hypoglycemia. So if a child, we are suspecting a problem of intoxication, so what we do is first we look at the plasma ammonia levels. And if the plasma ammonia levels are high, so we look at the ABG and look for presence of acidosis. And if plasma ammonia is high and the ABG shows normal, and if there is no ketonuria, so it goes in favor of urea cycle defects. And if the plasma ammonia levels are high, and if the child has acidosis, and if the child doesn't have any ketonuria, so it goes in favor of fatty acid oxidation defects. And if the child has a normal ammonia levels, and if the child has acidosis, if there is ketonuria, so then we have to properly suspect organic acidemia or mitochondrial disorder. If the child's plasma ammonia level is normal and if the ABG is normal, it goes in favor of amino acid disorders like phenylketonuria and peroxisomal disorders. And I said, we have to look as a clinicians, we have to be looking for the clinical clues. So if a child, if you are suspecting a urea cycle disorders, so these children, they present with race-like syndrome. So they have unexplained encephalopathy. So their liver enzymes are very much raised. They present with increased signs and symptoms of raised intracranial pressure. And if you look at their blood, they'll have hyperammonemia. And the clue that we get by if we do a ABG is the respiratory alkalosis. So a Ray's syndrome-like picture, hyperammonemia, respiratory alkalosis, think of urea cycle disorders. A child with organic acidemias presents with sepsis-like picture that we saw a second case where a child presented with acute gastroenteritis and the blood investigation showed sepsis-like picture. They would present like shock and the ABG shows high anionic gap metabolic acidosis. So sepsis-like picture, shock, high anionic gap metabolic acidosis, suspect organic acidemia. A child with maple syrup urine disease will present with hypertonia very early in the life. So they have opisthotonous seizures. And if the urine shows massive ketonuria, so suspect maple syrup urine disease. A child with non-ketotic hyperglycemia present with day one seizures. Day one seizures, and sometimes they also present in utero seizures. And when the child is born, when the child is consistently having these hiccups, myoclonus, opsoclonus, and normal labs. So we have to suspect non-ketotic hyperglycemia. So these are the clinical clues that we should be looking for in a child with IEM, especially the child who has presented acutely to us and the child who is in the ICU. And coming to a child who has got hypoglycemia as a part of IEM, which presents with energy failure. So first thing what you have to look for if the child is having hypoglycemia and you are suspecting a problem of IEM, look for urine, non-glucose reducing substance, and please do Benedict test, not glucose oxidase test, because Benedict test also picks up not only glucose, the other carbohydrates as well. So if urine glucose reducing substance is present, then it goes in favor of galactosemia. And if the urine glucose reducing substance is absent, then you look at the urine ketone bodies in a child with hypoglycemia. If the urine ketone bodies are negative, so we have fatty oxidation defects as we saw in the case that we saw earlier. And we can also think of hyperinsulinic states if your fatty oxidation defects is not diagnosed. If urine ketone bodies are positive, then look at the lactate levels. So if the lactate levels are high, it tells us that it could be a glycogen storage disease or a mitochondrial disease. And if the lactate levels are normal in a child with urine ketone bodies, where the urine ketone bodies are positive, so then we can think of congenital adrenal hyperplasia, hypopituitarism, or organic acidemia as the cause for recurrent or persistent hypoglycemia in a child with IEM. So many of these IEMs will also present as acute seizures or seizures can be refractory as well. So these are non-ketotic hyperglycemia, pyridoxine dependency seizures, folinic acid responsive seizure, glucose transporter deficiency. So any child whom the convulsions are not getting controlled, seizures are not getting controlled with your multiple anti-epileptic drugs. So I think all of us would start wondering about the possibility of these IEM and start giving these drugs like pyridoxine, folinic acid, and also look at the CSF to look for if there is any hypo or low glucose in the CSF. So glucose transporter deficiency is one of the common causes of an IEM where a child will present with recurrent seizures. So the problem is the plasma glucose levels will be normal, and the transport that happens from the plasma to the CSF glucose is deficient. So that is why our brain will be devoid of the glucose. So these children will present with recurrent seizures. So whenever we are suspecting an IEM in a child, so these are the investigations that we normally get it. So complete blood counts, we get a septic workup done, we look at LFT, RFT, serum electrolytes, and as I said, these are the screening tests that we get it done. GALAC, that is glucose, ABG, lactate, ammonia levels, ketone in the urine and in the blood. And these are the special investigations that we ask for: plasma amino acid analysis, plasma acyl carnitine levels, urine for organic acids, like we send for TMS and HPLC. And what is important is these special investigations should be sent at the time of acute illness. When the child has recovered, so all these metabolites may not be there in the blood, may not be there, or may not be found in the urine. So you may get a negative result. So when the child is acute, when the child is in the acute illness state, so it is better to send these investigations. And many a times, these abnormal metabolites can be picked up in the samples. And MRI, so many of these patients who have got encephalopathy, seizures, MRI could pick up a possibility of the possible diagnosis like MSUD will have restricted diffusion, central semi-oval like representations in the MRI scan. Symmetrical hyperintensities would be found in propionic acidemias and Lees disease. Glutaric aciduria will have wide opercula and cysts in the sylvian fissures and bright looking basal ganglia. So these can be clues that we can get by asking for an MRI in a child with suspected IM. And what is most important, whenever you ask for an MRI scan in a child with inborn errors of metabolism, is always ask for spectroscopy. MR spectroscopy is very important because MR spectroscopy will tell us what is the metabolites that are there, if it is increased or decreased in the brain, the metabolic activity in the brain. For example, in the Lees disease, we can find a lactate peak, which could be a diagnostic modality in diagnosing Lees disease, which is a mitochondrial disease. In a child with non-ketotic hyperglycinemia, so you can find a glycine peak. In a child with maple syrup urine disease, you can find a leucine peak. So the message is, whenever you ask for an MRI scan in a child with inborn errors of metabolism, you please also ask for MR spectroscopy. Coming to the investigation of a storage disease, the third child we saw. So storage disease, usually we get a bone marrow aspirate to look at the storage cells. And we also get the imaging studies, including MRI scan and the MRS. And tissue biopsies becomes very important. So we look at the tissue histology, histochemistry, and also electron microscopy. And many of these lysosomal storage diseases, we send for enzyme estimation. And the molecular genetic testing has become a boon now. So we can we are diagnosing a lot of metabolic syndromes or inborn errors of metabolism by sending the genetic testing. So we all should know when to send this genetic testing. That is very, very important. Don't send genetic testing upright. So at least you should have some knowledge. So what category the child's IEM belongs to, then only we can send for molecular genetic testing. So that is clinical exome sequencing, whole exome sequencing, and next generation sequencing. And coming to the management aspect, which is very important, and emergency management in many of these patients who present acutely to us is life-saving. And the final diagnosis is not required at the point when the child has come to us. Okay. And the treatment has to be started depending on the condition the child has come with. And the components of the emergency treatment include the supportive therapy and also the specific therapy. Supportive therapy is very important. You have to maintain the euglycemic state in these patients by providing adequate calories. And we all know that the catabolic, if there is a catabolic state, it adds on to the problems. So maintain the euglycemia, provide adequate calories. And when the child is a very small child, especially if it's a neonate or an infant, sometimes we may have to stop feeding in this child because sometimes protein load increases the problem. So stop at least feeding for some time and then we can restart it again. And many of these patients would require respiratory support. They will have raised intracranial pressures. They'll have encephalopathy. So many of these patients would require respiratory support. Maintaining normothermia becomes important. Correcting dehydration, correcting electrolytes, and correcting acid-base balance. All these things are very important, in stabilizing the child in a ICU. And antibiotics to treat infections and treatment of seizures. So these are the supportive care that these children would require. Specific therapy like substrate reductions can be done. We will look at each of these in detail. Provision of deficient metabolites, disposal of toxic metabolites, and increasing the enzyme activities. How all this can be done? Substrate reduction, the first step is to immediately discontinue the feeding, especially, as I said, if the child has presented in the neonatal period, which becomes the main source of protein and the lipid. And we should optimize the caloric intake by the administration of intravenous dextrose, which could be 10% dextrose, and slowly start the feeding. Protein is started with a 25% requirement with a gradual increment over a period of next few days. And when it comes to the breast milk, these are the only two contraindications of breast milk, of giving breast milk, that is galactosemia, and in a child who has got infantile, very long chain acyl-CoA dehydrogenase deficiency. And there are some medications that can be used to reduce the substrate, especially in a child where you suspect a child to have an organic acidemia. You can use metronidazole for about 7 days in a month to reduce the formation of organic acids and odd chain fatty acids. And there is a drug called as trihepatinoin that is used as an alternate substrate in the long chain fatty acid oxidation defects. And nitazoxanide, it reduces the substrate by blocking the pathway in tyrosinemia type 1. So all these things can be used when you make a specific diagnosis of an IEM. So without making a specific diagnosis, these drugs cannot be used. And provision of deficient metabolites, which is very important, like provision of dextrose. And we also use some special formula, especially in biotinase deficiency and in phenylketonuria. We know in maple syrup urine disease, in many of these amino acid disorders, these special formulas are available in these children. And if these children are put on special formulas, so their life would be as normal as any other child. And some medications can be used in a child with biotinase deficiency. You can use biotin, and zinc can be used in a child with zinc deficiency. And disposable of toxic metabolites, like when you suspect a possibility of an fatty acid oxidation defect, so you can use carnitine. Carnitine which will usually detoxify organic acids, and it is continued can be continued for a prolonged period. If you are suspecting hyperammonemia, sodium benzoate therapy of 250 to 500 milligram per kg in 2 to 3 divided doses can be started. And in difficult patients, where in one child whom I showed, there was a persistent metabolic acidosis, the child developed severe hyponatremia. So these children would require dialysis, hemodialysis and peritoneal dialysis. And some of the IEMs would also get better, especially there is accumulation of a lot of toxic metabolites by exchange transfusion. And increasing the enzyme activity can be done by administering vitamins and cofactors. And enzyme replacement therapy is coming in a big way, especially for those children with lysosomal storage disorders. And some of the IEMs with storage problems can also be treated with liver transplantation and stem cell transplantation. And this is the vitamin cocktail that usually we give to those children who present, especially with acidosis, whom we are suspecting a mitochondrial problem and organic acidemia. So where we are not sure about a particular diagnosis. So initially we start this, what is called as vitamin cocktail. And this vitamin cocktail usually contains these vitamins like biotin, and they are actually given in a little higher dose. Biotin, thiamine, lipoic acid, L-carnitine, coenzyme Q10, vitamin C, riboflavin, pyridoxine, pyridoxyl phosphate. All these vitamins are given. And many of these vitamins act as a cofactor for the functioning of these enzymes. And sometimes if you give these vitamins in a higher dose, so it may stimulate the enzyme production. And that is the idea behind giving this vitamin cocktail to the patients with IEM. Enzyme replacement therapy has become a standard of practice in treatment of lysosomal storage diseases. In India now, we have enzyme replacement therapy treatment possible in Gaucher's disease, Pompe's disease, MPS1, MPS2, and Fabry's disease. And the companies are coming out with these enzymes, and any patients who require this enzyme replacement therapy can be referred to a higher center where this enzyme replacement therapy is done. So, friends, coming to the summary of my talk, so we know that most of these IEMs can be picked up by the newborn screening. So always prevention is better than the cure. So once we know by our newborn screening that this child, if the newborn screening is positive, that this child could have an IEM, so we can be a little careful and follow up this child. And also, if the child develops any signs and symptoms, we can be ready in treating this child. And to suspect IEM, suspicion is the key. Is the key because most of these IEM will present as a case which we see normally, like a child present with an infection like that. So suspicion becomes key, and we should have a syndromic approach in making a diagnosis, and always as a clinician be looking for the clinical clues and get appropriate investigations and appropriate time. And as physicians, we should not miss the treatable IEMs, and good supportive management and correct metabolic problems becomes important. And whenever we are in trouble, please ask for the help and refer the child to a specialist. And in a sick child, it is prudent to think the common things first, and most of the times we are correct. But if the child is not improving, it is also important to think metabolically as well. So thank you for your patience listening. And if there are any questions, I would take. Thank you.
Thank you very much, sir, for really simplifying a very complex topic. I think we'll start with some of the questions to Dr. Rashna before we come back to you. Um, um, Rashna, madam, um, there was a comment about IAP waist circumference charts more than 70% is also significant for metabolic dysfunction. Whereas you said more than 90%. So is it 70 or 90%, ma'am?
Actually, the standard guidelines from all over the world says 90%. But if you look at the Indian charts, which are given, she's correct. The comment is correct. It is not 70, it's 75%. So if you look at the IAP charts, there's a red line there at 75, they have put a red line, which means that that is the cutoff. And if above that, then we are going to consider for a risk of metabolic syndrome. I agree with her for as far as the IAP waist circumference charts are concerned.
Okay, ma'am.
And I think that is important in our context because we have already have discussed that in our country, probably at lower BMIs and lower waist circumferences, will be more prone to get metabolic syndrome.
Now, that apart, any other, that regarding the use of drugs with these children for reducing the obesity, some more like drugs like metformin, is it of any use, ma'am?
In children, I think till now, the first recommendation is to try diet modification and exercise. But if some of the adolescents, if they're having polycystic ovarian disease, then there is a recommendation to give metformin in these children, not to reduce the obesity per se, but to act as a whole to take care of the polycystic ovarian disease, better insulin resistance control, and finally weight loss, but not as a primary drug for weight loss.
And in a family of obese family, would you think of some genetic test studies also for the child also, or would we kind of have a blanket approach and try to go ahead? Because this is a problem which we come across. We have mothers and fathers who are 120, 130 kgs, and the child at 10 years is 60 kg, and then you try to tell them, and then we also start wondering, is there a genetic component to it beyond the usual, the leptins or what?
There are no such genetic studies per se which have been the standard practice as of now. But it is easy to understand that if you have, I've already shown you the genetic part of in my presentation, where if one parent is obese, how much is the risk? If both parents are obese, then obviously higher risk. Obese child means obese adolescent and adults. So if it is the entire family is obese, we have to treat the entire family per se initially with diet modification and exercise regimen and try to see if it makes a difference. But there are some resistant kinds where you may think of genetic abnormalities. So in those cases, probably then it has to be a very specific kind of investigation. I have not done any such investigation till now in any of my uh, patient parent diets. So I would not be in a correct position to give you the advice. But we always, when we treat, it is always treat the family as a whole. Try to make, because the food choices of the parents are obviously bad, as well as the exercise choices or the act of not doing any exercise. So if you can modify that in the parents, and then they will do it on the child. So that would be the first approach.
So probably start weighing the parents also and put their weights also in the follow-up notes, so that
Yes.
it may
Yes.
probably maybe something which we can do.
Yeah.
So thank you, ma'am. Over to Dr. Pujar.
There is,
Sir, there
just
was a,
for that,
yes, ma'am. Yeah.
there is a question put by Dr. Dian Agarwal. Is
Oh,
ketchup
yes, yes, ma'am. Sorry, I missed it.
Yes, it
Sorry, yeah.
is. It is. If you try to do too much catch-up growth in the LVW babies, then it is definitely a risk factor for future metabolic syndrome. So we have to follow the growth chart, which is there for that particular weight, birth weight. We cannot, if the baby is born 1.5 kg, we cannot ask that baby or try to get that baby at 3 kg birth weight growth centiles. So it is correct. And therefore, I insisted on this topic when I was discussing in my presentation.
Okay, ma'am. So what would be like, let us say we get a 32 weeker at 1.5 kg, so we should put them in the bottom 10 centile or so. And if that's the case, would you then expect them to continue growing at 10 centile, or if the parents are enthusiastic, would we then allow them to get to 50 to 75 centile? How do
See,
we go
if
about
the
it?
baby is being breastfed, then it's well and good. If the baby is only on mother's milk and gaining weight in that centile or even going beyond that centile, it's fine. But it should not be that you try to give top milk and try to make the centile go up. That is wrong.
Okay.
That will
I
totally
think
spoil the
Dr. Srinivasan sir also agrees with
yeah.
you. And sir.
That will totally spoil the future of that child. There
Sir,
was
Srinivasan
another.
sir would comment, sir.
Yeah.
Sorry. Srinivasan sir, you want to comment on this, sir?
Me,
Yeah,
already she
please
has told
comment on
very
this. Yeah,
clearly.
yeah.
Yeah, as long as it's breastfed, it doesn't matter, but you must not try to overfeed and then make the child this thing. And that definitely will start, creating this metabolic syndrome very early in life.
Thank you, sir. Thank you, sir. So over to Dr. Pujar. Sir, there is a question about treatable IEMs. Anything briefly your experience or your comments regarding those? Sir?
Yes, nowadays most of the IEMs are treatable because most of these would present with hypoglycemias, okay, and also metabolic acidosis, okay, and we have many children who are also coming for the follow-up. For example, your medium chain fatty acid defects, like they only present with hypoglycemia. We have to take care of no prevention of hypoglycemia. So give them frequent feeds, and no, we also give them no frequent not only night feeds as well. And many of these amino acid disorders. So as I said, the special formulas are available. Like for example, in a child with phenylketonuria, so phenylalanine absent formulas are available. And many of these lysosomal storage disorders like MPS1, MPS2, Pompe's disease, enzyme replacement therapy is available nowadays. There are very
Thank you,
few
sir.
IEMs where total treatment is not available.
Okay. Thank you, sir. Thank you, sir. And there was a last question, probably. Dr. Agarwal again has asked, is there any metabolic cause of early morning cough, muscle cramps?
Yes, it is possible, especially glycogen storage disease, which predominantly affects the skeletal muscles. Okay, so they can present with IEMs can present with early cramps, muscle cramps,
Okay.
especially
Thank
glycogen
you, sir.
storage diseases, type 5
Thank you
macro.
very much. Before we conclude, I request a comment from Dr. Rajendra, President IFP.
Just before that, can I
Yes, ma'am. Yes, ma'am. Yes,
thank
ma'am.
Dr. Ahila for giving this comment about the NFHS 5 data. I did not look through it, but yes, I looked through it when she gave this. It's an extensive data, but it, I think, doesn't give you the actual picture. But what is good is that it at least tells you that obesity and overweight is increasing in India. So in adult male and female, from the NFHS 4 to NFHS 5, there is nearly a 2.5 times increase in overweight and obesity. But interesting data in the children is that there is not much of a rural and urban divide as per this NFHS 5 data. So that is also, I think, very, very important for us pediatricians. Thank you.
Thank you, ma'am. Thank you, ma'am. Yes, the rural children becoming obese is becoming a real problem these days, thanks to all the. And when you
Thirumurugan, can
look
I
at
make one comment?
yes,
Yeah,
sir.
please,
Yes,
sir.
sir.
Yeah, please.
Yeah, it's very important. Now we are taking everything to school level because it's very important that we go and conduct regular this thing. This was happening in when I was a student in Pondicherry Kalve College. They used to come and take the height, weight, and chest expansion, etc. And then, of course, we are also sent to have this thing, biochemical tests, especially for diabetes, etc. As early as 19, I'm talking about, before 1960. But I think now there are so many activities at school level. I think we have to orient teachers as well as this thing, parents, and there must be constant. And this type of adolescent, these things, these manuals were there. Some 9 chapters, and they had taken it to school. Similarly, I think it is very important that, both inborn error of metabolism, especially unexplained deaths in the family for more than, especially in consanguineous marriages, all these things should be brought into these things so that, awareness increases among the teachers as well as this thing. They themselves can send the patients, for checkup. Thank you so much.
Thank you, sir. Actually, one of the current in Dr. Rajendra's presidential action plan this year, there has been this extra drive to get this information across to students. And yeah, in fact, a couple of days back, he has spoken to the chief secretary of Tamil Nadu and also the education secretary to have programs so that we'll be able to reach out to the students, to the school children. So. Yes, sir. So we'll definitely try to include your comment also and then try to make it more robust. So thank you, sir. Before we conclude, I would request Dr. Ayan, sir, to have any couple
Yeah,
of
thank you, sir. And actually, both metabolic syndrome as well as that suspect IEM. So both are a very important topic because it's only suspicion only you can make the diagnosis. So sometimes it may mimic like cardiac, may mimic like sepsis. I think high index of suspicion only we can make out. I think definitely it's eye-opening for the practicing pediatricians as well as postgraduates. I really appreciate Dr. Rakshana Das, and as usual, she has done very well. And Madhu Bujar actually has enlightened all the how you suspect and how you approach that also is very nice for our practicing pediatrician. Thank you very much. Thank you.
Thank you, sir. I think I can say very safely that we achieved our aim with this particular topic. So thank you very much, our expert persons, Dr. Rasna
You are not
Das
touch
and
your aim every time, Dr. Tirumurugan.
yes, yes. Okay, sorry, sir. I think I'm just developing a new mannerism, maybe. I don't know. And Dr. Madhu Puja. So thank you very much, sir. I think we all had a wonderful session. As sir, you suggested, we'll upload it again separately and try to highlight it because it's something really, really useful. I think everybody should listen to it. So thank you very much for a wonderful session today. Thank you, sir. Good night.
Just before we end, there was a
Yes,
interesting
ma'am.
question.
Oh, sorry, I missed it,
Yeah,
ma'am,
it's
again.
asking for a model
We'll
diet.
provide as possible. Yeah. No, sorry.
Model
You
diet.
answered it also, but probably you can just voice it out
But
also,
there
ma'am.
is no model diet menu, one menu, because you see, India is very
Varies.
diverse. Whatever I say from Assamese diet will not be applicable to a Tamil Nadu diet. But what I can tell you is that the traditional diets are always better. The ones we have with curd-based
Protein.
diet, you know? And here in Assam, especially, we take a lot of vitamin C rich foods, very less oil, lots of vegetables. If you can introduce the traditional diet in the let the children have the traditional diet, then I think most of our problems will be solved. Thank you very much again.
Thank you, ma'am. I think even parting comments had a lot of information. So thank you very much, and I think we'll close today's session. Thank you very much. Good night.
Good night, all of you.
Good
Thank
night.